welcome. This is Dr. Tofi. Welcome to HerniaTalk Live, our weekly Q&A on Tuesdays. I am your host, Dr. Shirin Tofi, hernia and laparoscopic surgery specialist. Thanks to all of you for joining me live currently on Zoom and as a Facebook Live. As you know, you can follow me on Instagram and Twitter as well at HerniaTalk. And at the end of the show, this and all prior episodes are available to all of you on YouTube. And pretty soon I will announce my podcast version as well. But I'm very happy to introduce to you a good friend of mine, Dr. Larry Orbuch. Dr. Orbuch is a gynecologist, but his specialty is in endometriosis treatment. And he sees a lot of women with chronic pelvic pain and understands hernias. So it's like going to be a great discussion today. So you can follow him on Instagram at Dr. Larry Orbuch, and please give a warm welcome to Larry. Hi, how are you?
Hi there. Thank you for having me. It's a pleasure to be here.
Thank you. So, I know I first learned about you from my colleagues in New York because you used to practice in New York.
That's correct.
And then you moved to my side of the world in Los Angeles. Maybe you can explain what you were doing in New York and how you got into being a specialist in your field.
Sure. So I've been in practice now for over 20 years, like close to 24 years. I was in practice in New York until about 7 years ago when I moved my practice out here. Mm-hmm. And my focus has been on endometriosis and chronic pelvic pain and the treatment thereof, both surgically with minimally invasive surgery, as well as treating all the coexisting symptoms and pain generators that most people who have endometriosis usually suffer from. Mm-hmm. What I found in my early years of practice is that it was a kind of a void in the availability of good care in this area, and the paucity of people available to provide it.
And what did you learn that in residency? Like, was there someone in your residency that kind of showed you that there's this kind of void or was it once you were in practice, you decided there's this population that's not being treated necessarily optimally?
Yeah, I noticed that it was something that was not given a lot of focus during residency, and the level of awareness among practicing physicians, not forget about residents and people in postgraduate training. When I started to really analyze it, I realized how minimal the amount of education that you get in medical school, and even in residency in obstetrics and gynecology, where that is what your area of study is. And it was not really given the amount of focus and attention that it should have. And I found also that the approach that many practicing OBGYNs had was very outdated. They were still quoting the not even literature, but the theories about endometriosis that had been postulated over a century ago.
What were those theories?
So the
that are no longer.
Yeah. So the famous one is called Sampson's theory, which was postulated by a general surgeon named Dr. Sampson back in the 1920s, okay, who incidentally found these implants or growths in patients when he was operating on them, not necessarily for that, for other things. And he biopsied them and looked at these specimens under a microscope, and it looked like endometrial glands and stroma, or the connective tissue under the glandular epithelium. And so he just assumed, based on the level of knowledge in the 1920s, that if looks like endometrium, it's in the abdominal cavity, it must be coming from the endometrium. Hence his most logical conclusion was that there was what was called retrograde menstruation, that there was flow of endometrial tissue out from the inside of the uterus via the tubes into the abdominal cavity, and that's how it was getting there.
Is that incorrect?
It's kind of half true. So
Because that's what I was taught too.
Yeah. So I believe in the 1950s they did some studies where they did like real time, like fluoroscopic imaging of women during their period, and they found that pretty much most, if not all, women have some degree of retrograde flow in the period, because as the uterus contracts when you're having your period, you can't, the bulk of the flow comes out, through the canal into the cervix and into the vagina. However, there is some degree of retrograde flow out through the tubes.
Out through the fallopian tubes, which communicate with inside the belly around the intestine.
Exactly. So that's a direct communication into the abdominal cavity.
So they did like a fluoroscopic study, which showed, in fact, that happens in a lot of patients.
Right.
And they don't get endometriosis.
Exactly. So that whatever was flowing out generally gets reabsorbed by your body and doesn't really do much.
Because it's blood.
Yeah, it's mostly
like
blood.
Any bleeding inside. Yeah.
Right. So just to kind of take a sidetrack, and I'll get into more details about that. What we have found and what's been theorized also is that perhaps women with endometriosis do have a harder time of clearing that. So if they have endometriosis and they get that added flow out of the tubes, they may not be able to process it in the manner in which is necessary in order to eliminate it. But the actual etiology and the pathophysiology of how these implants arrive where they are is more so one of a combination of things. One, the most prominent component of it is that during embryonic development, when an embryo develops in the uterus,
when you're a baby,
right, and you're developing little baby, or even before you're a baby, an embryo, there are three cell lines that differentiate into all the parts of you, and the endoderm, ectoderm, and mesoderm. The mesoderm, some of the structures that it creates are the whole urogenital tract, meaning uterus, tubes, ovaries, ureters, bladder, kidneys, and lots of other structures in the pelvis and lower abdomen.
Okay.
During that process, these cells migrate to different places and then differentiate into these different structures. So for some reason, some of these cells are kind of go haywire or programmed differently, and they can end up being dropped off or stuck in places that they shouldn't be.
Oh.
And that's how you end up, with these implants in strange places. And we know this all fits into the whole puzzle of the greater picture of endometriosis, because we see a lot of endometriosis, not a lot, but there's a fair amount of endometriosis patients that have other structural developmental anomalies that we see, of which kind of goes into the realm of the urologist and general surgeon's domain, where there are deviations in how the whole urinary tract forms, and they can end up with either one kidney or two kidneys on one side, or double ureters, or so we usually, when there's something odd in the history and they have endo, we'll usually work them up to make sure that there's not something else that we're missing. There's also developmental issues with the uterus, where there's a high incidence of uterine septum, where the uterus, when it develops, it doesn't fully develop, and you end up with this central it's kind of connective tissue-y cartilaginous tissue right in the midline at the top of the uterus, which can result in people having difficulty getting pregnant, because the fundus, so the top part of the upper wall of the uterus, is probably the most prime real estate for implantation of a pregnancy. And if you have a septum there, it's not well vascularized, so it makes it difficult for a fertilized embryo to implant. So we usually look for those things as well, because those things like a septum can be repaired at the same time as we deal with the endometriosis surgically.
Got it. I see. So some people, I mean, I heard about it. I've never seen it myself, where they say, oh, there's endometriosis in their eye and endometriosis in their lung.
Right.
I think those were part of a developmental anomaly where those cells just happen to hang out there inappropriately.
Yeah. So for the longest time, until several years ago, the only surface or organ that endometriosis had not been identified in was the spleen. But more recently, there have been case reports of splenic endometriosis as well. I've seen patients with nasopharyngeal endometriosis, lung endometriosis, diaphragmatic endometriosis. You can have it in the brain, thyroid. I mean, you name it, it's been reported. So there's definitely an embryonic developmental factor. There's questions as to how they get triggered. There definitely is a hormonal component to it, where usually with the onset of puberty, that's when things get worse, because with the ovarian function revving up and you having more circulating estrogens, that stimulates these implants, just like it stimulates the endometrium, the lining inside the uterus.
Wow.
And then there also have been environmental factors that have been associated with it, like dioxins, which are the byproduct of bleaching and other chemical toxins and radiation and different environmental exposures have been found to be triggers. And also in lab animal studies in rats, they found that with super physiologic dose exposure, they can trigger these implants. There was even a study, which I think we discussed when we spoke last, done in Italy, where they did autopsies on female fetuses that were miscarried, and they found the incidence of finding of endometriosis intra-abdominally was pretty much similar to what the rate of endometriosis is among the adult population, which was like 9.4% versus about 10% is what we find in the population at large.
Wow.
So it's probably some multifactorial sort of a pathway that it takes. One component may be more prominent than another in a particular individual. There's a big genetic component to it as well. And people who have at least one first degree relative with endometriosis, that puts them at a 7 to 10 times greater risk of having endometriosis. So mother, aunt, sister, grandmother, either maternal or paternal.
Yeah. But I feel like older generation people were not being diagnosed with endometriosis.
No, they weren't. They were basically being labeled as generalized chronic pelvic pain.
Yeah.
And they usually would end up the typical story that I hear when I speak to patients, when they tell me about their family, like mothers, grandmothers.
Yeah.
The classic is, oh yeah, my grandmother had problems and she had a hysterectomy when she was 30. Big red flag, like, did she have fibroids? No, she just had really painful periods and whatever. And the old school, and unfortunately not so old school, because I still see now that have had hysterectomies as treatment for endometriosis, which it's not.
Can you explain why hysterectomy is not a treatment for
Of course.
endometriosis?
So endometriosis is when you have these implants outside the uterus. So if you have endometriosis, the only way to treat that is to excise those implants,
which are outside the uterus.
Right. Adenomyosis is a component of endometriosis that involves the uterus. And that's when you have invasion of this glandular tissue.
That's endometriosis in the wall of the uterus.
Right. So it invades into the wall of the uterus. The uterus is made out of smooth muscle.
Yeah.
And it basically interlaces itself in between the muscle fibers. And that can cause pretty much most of the same and similar symptoms as endometriosis, but generally more heavy bleeding, possibly, but it's not something, if that is the major component of what's going on, or the excision of the endometriosis doesn't do the trick, and you have diffuse adenomyosis, then the only treatment for that is hysterectomy. But note that I said diffuse, because generally if it's minimal or focal, it may not be really adding a lot to the symptomology. So
if you have endometriosis limited to the pelvis or around the uterus area,
right.
Are those people that have it because they're having retrograde menstruation and it's implanting?
Yeah, no, usually if you have adenomyosis, there's endometriosis too. I mean, I would say, if I was a gambling man, I would put even odds that if you have adenomyosis, there's endometriosis in the pelvis. Because I've seen patients who they've had an MRI and they've been told that they have adenomyosis, and their doctor goes in and does a hysterectomy with blinders on, doesn't look anywhere else outside of the immediate area of the pelvis where the uterus is. And they miss the forest for the trees. So they take the uterus out, and then sure enough, patient is still symptomatic. They may not be as symptomatic, or they may be just as symptomatic. But then the only way to treat that is to go back in and remove the endometriosis.
So taking adenomyosis out of the picture, if you only have endometriosis outside the uterus, is a hysterectomy ever a treatment for endometriosis?
No, if the uterus is not involved, then there's really no real justification for
I know so many patients that are either recommended or have had hysterectomy for endometriosis.
Right. So it's doing
not adenomyosis.
It's doing the wrong surgery for the wrong condition.
Okay, but endometriosis is hormonally activated, right?
Yeah, but you can it generally tends to be more hormonally influenced, obviously, in someone who's premenopausal. However, it can continue to be just as or almost as symptom causing, even peri and postmenopausal.
You can have endometriosis postmenopausal?
Yeah, it doesn't go away. It's still there. And the unfortunate thing is, if you have long-standing endo, that's been going on for decades, and then it's a progressive condition. There's always a potential of it becoming deep infiltrating lesions, and that can result in heavy scarring and adhesions and nerve entrapment and nerve impingement, where the lingering pain may be from that and not from active, plump, juicy lesions.
Right, from this negative side effect of the damage that's done by the endometriosis.
Right. And that's why it's another misconception when people are told by their doctors that they just wait until you go through menopause and everything will be fine. Pardon me. I mean, I can't tell you how many patients I've seen who they've done that with, and now they had that implant that they had on their ureter has now completely invaded the ureter, and they're obstructed, and their kidney is now dead on that side.
Oh my God.
Or they've had an infiltrating nodule in their rectum, and now it's partially obstructing the rectum, and you have to do a rectal resection with a colostomy, and it's not something that you can wish away. I'm not saying that those extreme cases are what happens with great frequency, but happens often enough, and even without those extreme situations, you still have the quality of life issues. So if you're miserable and in pain and can't function, the fact that you're postmenopausal, so you're not having your period anymore, or you're irregular, but you're still having as much if pain is you did before.
So this, what you're teaching right now, and I'm learning, is not necessarily taught during residency.
No, no. I mean,
Wow.
it's. Look, I think part of the problem is, as medicine evolves, people tend to, become more and more specialized in different areas,
Yeah.
and general practitioners are kind of swimming in a shallow pool, so they know they know a
Yes.
little about a lot of things,
Yes.
and uh, which then ends up leading to people pursuing these niche areas where you can really focus on these issues. I think
Yeah.
the other issue in OBGYN training is that it's kind of a double-edged sword with the advent of a lot of these subspecialties even within our specialty.
Hmm.
A lot of surgical exposure and experience that we used to get when we were residents is taken away, and it is done by these specialty fellows, and rather than the general residents. And that's why they've been talking about now for years about creating two different tracks in training, like the
Oh, for,
general.
for gynecology.
Yeah, like doing the obstetrician who does minor general GYN, and
Hmm.
then the gynecologist who basically specializes in gynecology and all the surgical, issues of
Wow.
gynecology. So that I think that's somewhere coming down the road. But
Does taking out the ovaries treat endometriosis in any way?
so it doesn't treat it. I mean, it will diminish the hormonal stimulation by decreasing your hormone levels, because you
Yeah.
basically put into an induced menopausal state. So I don't routinely recommend, if you have normal ovaries and you're having endometriosis surgery,
Hmm.
uh, especially if you're far away from menopause, that's the downside to taking the ovaries out is far greater than any
Yeah.
potential future issue that it can add to vis-a-vis endometriosis.
It's so interesting. So, general surgery, we're in a similar bind, which is there's so much to learn in the 5 years of training, and most general surgery residents now that graduate end up doing 1 to 3 years of extra training to
Right.
more or do better or be more specialized, because there's just too much to learn. But there's actually something called rural surgery, which you have to be able to deal with a very wide range of surgical problems, because you don't have specialists nearby.
Right.
Um, and hernias are very much a specialty that all general surgeon, or it's a topic that all general surgeons should be able to do. Right? It's considered, the most common outpatient surgery done by a general
Mhm.
surgeon is a gallbladder or hernia surgery.
Right.
Uh, but now we are also specialized,
Mhm.
because, I could be sitting in your space now and telling you all the stuff that I learned in residency that are completely wrong, that I'm no longer doing as a hernia specialist. And people to this day, the majority of them are still doing it incorrectly, and they don't even know.
Yeah,
Yeah.
and it's the same thing like in the realm of endometriosis. The the proper surgery is to do excision surgery, where you actually excise, you cut out and remove the disease. The wrong way to do it is the easy way, which is what most people do who are not experienced surgeons, is to do ablation, or you burn it, fulgurate it,
Yeah.
laser it. So you're basically zapping these lesions, and
Yeah.
the recurrence / persistence rate with ablation is over 35%, whereas the recurrence rate with excision is in the single digits, depending on which study you look at. It's between, I believe, 3 to 9 point something percent.
Yeah.
So to do proper excision requires a lot of dissection and knowledge of anatomy, and it's also time consuming. And most people do not have adequate skills or experience to do that. So they do what used to be acceptable, which is ablation, and essentially leave the patient either no better off or sometimes even worse off than they were beforehand.
Yeah. So the topic of female pelvic pain, we kind of titled this as like surgical approaches to female pelvic pain, because endometriosis is very much a surgically approached disease. There are hormonal ways, I think, of monitoring it or managing it, but what percentage of patients that have endometriosis need surgery?
So it really is a matter of the individual clinical scenario. If you have a high suspicion, because let me say this, go backwards a little bit. It's a presumptive diagnosis until you actually do a laparoscopy and look inside.
Oh.
There are telltale signs and symptoms that will, make you suspicious of its existence, but there's no imaging study that will diagnose it. There's no blood test. There's no medical conservative way of diagnosing it, unfortunately. But when you ask all the right questions and you get all the answers where all the arrows point toward endometriosis, that's kind of where you get to the scenario of telling the patient, I think you have endometriosis, and we can treat a lot of your coexisting symptoms that are triggered by the endometriosis, but ultimately the only way to really address it is to directly treat it by doing laparoscopic surgery and excising and removing the lesions, and also dealing with any other issues that are going on, like adhesions, scar tissue. We incidentally a lot of times find things like hernias that can be additive to their pain. The appendix is oftentimes involved as well, and if you leave that behind and there's endo in the appendix, you're never going to eliminate all their symptoms. So it really, and then kind of jumping to another side of the coin, which is the realm of fertility and pregnancy. It's pretty significant. Statistics are pretty significant in that over 50% of women who have unexplained infertility, meaning they've had $1 million workup, IVF cycles, et cetera, and so forth, half or more of them have undiagnosed endometriosis. So the recommendation by the American Society of Reproductive Medicine and the American College of OBGYN, in those scenarios when everything is normal, negative, the next step is a diagnostic laparoscopy. Even if they're not symptomatic, because you've ruled out every other cause. So that then there has to be something organic going on or anatomical that's resulting in their inability to conceive. And the interesting thing about endometriosis, unlike a lot of other conditions where you pretty much expect people to have certain symptoms in order to have the condition, or a certain degree of symptoms. With endometriosis, you can have people who are minimally symptomatic, and then when you operate on them, they have significant amount of disease, and you can have the reverse, where they have significant amount of symptoms and very pinpoint minimal disease, but for that person, that's what it takes to trigger all these issues, symptoms, and in the realm of pregnancy, infertility. So it doesn't follow a set pattern, and quite frankly, I find that even people who are referred to me by the reproductive endocrinologist, they say, well, my doctor sent me to see you because she thinks, maybe I have endometriosis, but I don't have any symptoms. Invariably, when you sit down and you take a thorough history, there's always symptoms. The problem is, it's what I call the new normal. These people have been dealing with these symptoms for so many years, and it's slow in onset and insidious. And they think that, being miserable and curled up in a ball, with a heating pad for 24 or 36 hours every month when their period starts, they think that's normal. And they've been told that's normal. They've been told that by the pediatrician, then their mother's got OBGYN, and then by the school nurse when they're in high school and in college and whatever. And they get, and this is how it's easy to understand how the delayed diagnosis is over 10 years. Over 10 years.
This is what I'm dealing with occult inguinal hernias. So in women, hernias are always smaller than men to begin with.
Right.
And the really small ones often are really symptomatic. Like they have pelvic floor spasm and painful sex, and they have groin pain radiates to their vagina around their back. It's worse with their menses. It's always activity related. And they go to most doctors and they're like, either you don't have a hernia or that's too small to cause pain.
Right.
And yet for that person, you fix the hernia and it gets better. And it's hard to get other surgeons to believe that a small little piece of fat in an inguinal canal can cause so much pain and disable some people.
But this kind of goes back to what we were talking about before is level of experience and exposure. You and I see
the symptoms are correct.
Right.
Yeah.
You and I see the whole spectrum, and we see them. And I've seen my share of. Incidentally, I go in, they have endo, but they have this little inguinal hernia with a wad of omentum tucked into it.
Yes.
And or they have, and people are like, no, there's no way you can have a hernia, and never pregnant, but they have a diastasis with a loop of bowel or omentum stuck or on the umbilicus. And I'm sitting there, I feel like I'm like a magician pulling the rabbit out of the hat. I'm like, you think it's just a little, and you just keep going, and I'm like, I can't believe she wasn't even more symptomatic.
Yeah, but even the small, because I've been in operating rooms with gynecologists similar to yourself that they may have a hernia, and then you gotta look in there for endometriosis, or vice versa. They're going in there for endometriosis, they want me to be in there for the hernia. And you'll see like one spot. But you know what? That one spot may be the spot that's causing all the symptoms. You don't have to have stage 4 endometriosis where everything is stuck to each other. And
absolutely.
So interesting. And I've seen stage 4 endometriosis where the gynecologist would make the comment of, wow, I'm surprised she's not more symptomatic.
Right. And I think in my personal theory, which there are many in this area that agree as well. I think there's an autoimmune component to this, and how the individual's immune system, and how the individual patient, how their immune system handles things that are inflammatory, things that are foreign, or things that are in places that they ought not to be. And that varies. And I've seen similar kind of things where I've gone in, the patient is not really super symptomatic, but it's more so because of fertility. And and it's everywhere. And you're like, you sit there scratching your head, you're like, I can't believe that she wasn't like way more symptomatic than she is.
We talk about the medical treatment, because I've seen doctors go in and see like what you just said, endometriosis everywhere, on the bowel, on the peritoneum, between the uterus and the bladder. So then they come out and they say, oh, we're just going to stop. We're not going to do surgery. We're going to start Orlissa or Mirena, IUD, or some type of hormonal medication, and then maybe come back later. Is that valid?
No, so that's really not a valid approach, because if you look at medications like the birth control pill, the progesterone IUD, Orlissa and GnRH agonists. The only thing that they are FDA approved for is to decrease pain during your period, dysmenorrhea. That's the only thing. It's not indicated or cited as being helpful for anything else. It does not treat it. It does not halt the progression of it. It doesn't melt it away like some people are under the misconception. And unlike the pill and the IUD, these medications like Orlissa and Lupron, the GnRH agonist, put you into a chemically induced menopause, which comes with all the wonderful side effects of menopause, and some of which are reversible when you stop medication, and some of them are irreversible. And I've seen young patients who are in their late teens and 20s who were put on these medications for years, and they aren't even approved for use more than a half a year or a year, depending on the dose. So, logically, you ask yourself, like, why would you want to go on a medicine that you can only use for 6 months or a year?
Right.
Where are you going to end up after that 6 months or a year? Right back where you started from. So you're basically, it's, to call it a Band-Aid would be a compliment, because it's not even that. Because, and my personal experience is I have never, or almost never, encountered a patient who has been treated with those medicines who reports having benefited from it. They usually were more negatively impacted by all the side effects than they were by any decrease in the pain during their period. So they're equally as effective as the pill or the IUD. However, the pill and the IUD are reversible. You stop taking it, its effects, will disappear.
Yeah.
But the bottom line is, in people who are not severely symptomatic and they're very reticent about having surgery, you never push anyone into doing to having surgery, but you just educate them. And what I generally do is someone who's not ready to have surgery, who doesn't want surgery, I'll treat all the other issues. I'll treat their painful periods. I'll put them on the pill. I'll put in a progesterone IUD. I'll send them. They have tight pelvic floor muscles. I'll send them to pelvic floor physical therapy. I'll treat their GI symptoms because there's a high incidence of a lot of inflammatory conditions of the GI tract, like small intestinal bacterial overgrowth or SIBO, leaky gut syndrome. There's, which leads to food sensitivities and food intolerances. There's also a high incidence of an inflammatory condition of the bladder called interstitial cystitis, which gives people kind of these UTI symptoms. So that a lot of these patients, they'll tell me, "Oh yeah, I have UTIs all the time," and then when you start really investigating it, it's not. It's just this inflammation on the bladder, which triggers pain, which causes symptoms that are akin to UTIs, and it also mimics a lot of the endometriosis symptoms. And that's why in the literature they refer to interstitial cystitis, or IC, as the evil twin of endometriosis, because there's a lot of overlap. So you need to treat all these coexisting pain generators and issues, which will make someone feel better. So if you can, in the interim, improve their symptoms by 20 or 30 or even 50%, that's fantastic. And that's something that I do whether or not someone is planning on surgery, in the immediate future, because you want to start helping people dig their way out of the misery of all the chronic pain that they've been having. And by addressing all these things, you give them positive feedback in seeing that, oh, I can feel better, and this is working, and it just changes their entire state of mind. You give them hope and optimism that that if I stick with this, I'll get out of the woods.
Yeah, there's so much overlap. This is fascinating because the people that I see, the women with chronic pelvic pain for years, decades, like you said, and then some of them, because their pain is worse during their menses, are already told, oh, it's endometriosis. But they still have pain in between, and it's often activity related, which is not endometriosis.
And that's a very good point you raised, because there are cyclic types of symptoms, and then there are acyclic or cycle independent symptoms. So, and that's another one of these general misconceptions that many physicians have. They think,
Yes.
oh, if you're having pain outside of your period, it can't be endometriosis. Or if you don't have pain during your period that's particularly bad, but your pain is outside of your period, then that can't be endometriosis either. There's no checklist of things that are diagnostic.
Yeah.
For endometriosis. You really, it's more nuanced than that. And the important thing is to get a thorough history.
Yeah.
And then to look logically. I mean, when something doesn't make sense, you got to take 2 steps back. I see, for example, a patient who's 20 years old and has been miserable since they were 11 years old when they went to puberty, and they have painful periods, pain outside their periods, back pain, bloating and GI issues and bladder issues and anxiety and depression and sleep disorder, blah, blah, blah. You go on and on, and you're like, wait a minute, what disease does this person have? And you ask them, do you have any medical problems? They're like, no. And they've had the $1 million workup. They've seen the gastroenterologist. They've had a colonoscopy, an upper endoscopy.
Colonoscopy, twice.
Motility studies, barium swallow, you name it. They've tested them for celiac and for Crohn's, and they have nothing. They have nothing as diagnostic. They label them as IBS, irritable bowel syndrome.
Yes.
And they give them some Bentyl or some other antispasmodic, and they pat them on the head and send them on their merry way.
Right.
IBS is not a diagnosis; it's a description. Right. Why are they having irritable bowel syndrome? And unless you determine that, sorry, what you don't have a diagnosis.
So true.
And you have to look at the bigger picture. You're like, why is this person having all these unrelated symptoms?
So true. Because for inguinal hernias, the small ones especially, you can get bloating.
Right.
And so they get the full workup. Why am I bloated? I feel like almost any pelvic kind of pain thing can cause bloating. And it gives you pelvic floor spasm. So they have like frequent urination, burning with urination, intercourse is painful. Right. So they're labeled with interstitial cystitis because of that component of it, or some type of kind of pelvic floor spasm without a reason for it. And all they need to do is get their hernia fixed,
and with the pelvic floor dysfunction, the tight pelvic floor muscles, people minimize that, but you think about it logically. The pelvic floor is sort of like a hammock of muscles that kind of interlace, and they support everything above it. And through that, this, but I'm just for our audience.
Yes, I love it.
The through that pelvic floor run some very vital structures: the urethra, the vagina, and the rectum. Yeah. If they're trapped in the muscle sheaths, if they're in there and the muscle tone is really tight or hypertonic, it's squeezing all those things. So that's why I have patients who complain of feeling like this weird pressure and spasm when they urinate, extreme spasm and tightness during intercourse, because pain with bowel movements. I have patients who report feeling like someone's strangling their rectum, or they're passing broken glass through their rectum.
Oh, or they feel like they have to go, but they can't. They don't.
Right. And you, so if you don't, even if you treat and you do the surgery to remove the endometriosis, if you don't treat that pelvic floor dysfunction, if you don't treat that SIBO, if you don't treat that interstitial cystitis, if you miss that hernia, if you miss that abnormal appendix, you're never going to get to the best place possible.
Yes.
That's why you have to.
Can you talk to me about the appendix when you go in there for pelvic pain, right? So unknown reason for chronic pelvic pain. You go in there laparoscopically to take a look. Let's say you see a little bit of endometriosis. What do you do with the appendix? Is it still something that
generally I remove them.
Oh, you do?
I published a paper a couple of years ago in the big international laparoscopic journal of what my experience has been, and over 18% of these appendices were abnormal with endometriosis in them, but there were another 25% that had other abnormalities, I
Yeah.
picked up some carcinoid tumors, some primary cancers of the appendix, chronic appendicitis, acute appendicitis, something called fibrous obliteration, where the pathologist looks, they section up the appendix and the entire lumen, because as we know, there's a cavity inside the appendix. It's completely gone. It's just scar tissue.
Wow. And
so
do you have a general surgeon do that, or do you do the appendectomy?
Usually I have a general surgeon in there, because especially in patients who have other bowel issues where there could be potential need for bowel resection or hernia repair. I can do the appendectomy myself, but they're there anyway, and they're usually addressing other things as well. And that's another thing that I think is underestimated, is being prepared.
So true.
It's better to be over prepared than to be caught like in a situation where you're over your head. So if you think there's going to be bowel involvement, if you think there's going to be issues with the bladder or the ureter that are out of your domain of expertise, then first of all, get a proper workup, because a lot of times you'll pick up things which will definitely tell you there's a nodule of endometriosis invading the bladder. You're going to be resecting that part of the bladder with the endometriosis, or there's a lesion into the ureter, or there's a rectal nodule or a sigmoid nodule. You want to be you want to do the best thing for the patient, and avoid having to go back in, because you get in there and you're like, oh my God, she needs a bowel resection, but I don't have a general surgeon. So it's sort of a multi-specialty approach, because there's so many things that can be involved that are in the domain of other specialists.
Yeah, it really is. I have a question about endometriomas. Endometrioma. I had a lady who went to a cancer hospital for her endometrioma, and they treated it like a tumor. They took out all this huge, it was in her abdominal wall. So it took out not only the endometrioma, but also like a huge round, defect of abdominal wall, left her with a huge cavity. Endometriosis is not cancer. You don't need to remove it with positive margins. In fact, you don't need to have any margins. Is that right? Or
you don't, but if you leave residual disease behind, it's going to keep doing its thing.
Sure.
I've had cases where with abdominal wall masses that were endometriomas, either from direct extension from the ovary, or just a lesion, from C-sections, or even just a lesion that was in the peritoneum, the lining inside the abdominal cavity, that invaded into the abdominal wall. And I've had bad cases where it's basically grown into muscle in the abdominal wall.
Yes.
We have to do a major resection. It's very it's unpredictable. It's far more, almost more unpredictable than malignancies or cancer. And it really, from the standpoint of eliminating the potential for future, for continued or future symptoms and future issues, dealing with it as definitively as possible is ideal, to be able to avoid having, the patient have to have subsequent surgery.
And if you have endometrioma, which is call it chocolate cyst, or like a ball of
so classically endometrioma is a cyst in the ovary, where endometriosis has now kind of burrowed its way in and created this walled off collection inside the ovary. So those you have to remove by basically opening the ovary, shelling out the entire cyst wall with all that material that's inside it. Because if you just drain it and burn it, it's just going to seal back up and reaccumulate. So that's another thing that has to be done properly, just like excision of implants. Proper excision of the entire cyst itself, along with its content, is the appropriate surgery.
Yes.
For endometriosis.
Excise the cyst and its contents. And then if the liquid spills, it's not like it's going to implant again, right? You can just wash it
Well,
off.
yeah, so generally what we try to do is dissect it out intact if possible, then put in a specimen retrieval bag into the abdominal cavity, put the cyst inside the bag, then put in a suction device into the cyst wall, suck out all the material so it deflates. And then
Yeah.
you're containing everything. You've got the fluid out, you've got the cyst inside this bag, which you then cinch closed, and you pull it out. Because one of the,
So
when
get it into where your scar is.
right, so that's how people end up with implants
course, like
in the
endometriosis.
incision.
Yeah,
So you want to keep that away. You don't want to be tracking things, endo through the abdominal wall.
Got it. There's a question about how do you handle endometriosis involving the nerves?
So that's a good question. So depending on where these lesions are located, there's two ways that it can impact nerve, either by direct involvement or invasion, or by the neural communication from nerve fibers that transmit pain. The unfortunate thing with endometriosis implants is they emit different substances. They emit a lot of inflammatory mediators like cytokines and interleukins and things like that.
Okay.
But in addition, they also release nerve growth factor and vascular growth factor to help itself grow even more. So what you find when if you look at an implant over time, it will develop more nerve fiber connections, which then communicate via the peripheral nerves to the central nervous system, and and that's a big part of the pain, as much as the direct, type of visceral pain that the endo can cause itself is the upregulation of the whole central nervous system. Mm-hmm. When you have chronic pain, which by definition is pain that lasts more than 3 months, you're now in that chronic pain domain. So these pain signals are just continuous, and you and I know that the way that the central nervous system is hardwired, it's not linear. It doesn't, you have pain in your pelvis. It doesn't, there's not one nerve that goes to your spinal cord up to your brain, communicates, and then there's a signal back. It jumps via different fibers. It jumps to different levels in the spinal cord, and then in neurologic terms, it's called crosstalk. And this is what you see with chronic pain. So as these signals are going back and forth, they start communicating with other nerves locally and also in distant places. And that's why you get, what starts out as pinpoint right-sided pelvic pain becomes bilateral, meaning both sides, radiating to your back, radiating down your leg, neck pain, shoulder pain, abdominal pain,
this whole syndrome,
migraines. It just takes on a life of its own. So with direct involvement, then it would entail, if you have, like, I've had nodules that have put pressure on nerves. I've had, implants or nodules that have grown into nerves. So that's a much more involved dissection. You really need to isolate, what's being triggered there. There are procedures like neurectomies where they sever certain sensory nerves to lessen symptoms. It has varying degrees of success, but it's one of those things where you really have to. It's an individualized diagnosis, and there are diagnostic tests you can do, like MRNs, which is an MRI that you're looking at nerves. Right. So it's key to have a proper workup.
For groin hernias, a lot of people have nerve pain, so it's usually ilioinguinal nerve, sometimes nerve branch, not because the nerve is injured, but because the nerve is somehow being touched, pinched, poked at by the herniation.
And it's being hyperstimulated, and it's continuous.
But people focus on the nerves. They go to the doctor, I got nerve pain. Well, you do have nerve pain. Because you go down the whole nerve pathway.
Right. And you have to be careful, because when you start, when you start severing nerves and nerve
Yes.
trunks, you can have unwanted sequela from that, where nerves that
Yes.
you don't want to be affected are affected, which can lead to other issues. So it's not something to
Yes.
be taken lightly.
Yeah, we've discussed that in the past with some of our pain doctors, because there's something called complex regional pain syndrome, and
Right.
can spark more nerve pain by touching and cutting those nerves. So sometimes I do neurectomies as needed for chronic pain purposes, especially if the nerve's been damaged from, let's say, a prior hernia repair. But
Right.
there's absolutely no reason to cut nerves that are healthy.
Absolutely not.
Yeah. So do you still practice in New York, or you're completely in Los Angeles?
I still, well, COVID kind of neutralized that for a while. I may do that periodically. I still have a lot of patients on the East Coast, but many of them have come out here, so
Yeah.
it's to be determined.
Okay, good. It's good to travel. It's fun.
Yeah.
And then I assume you see patients from out of state. Do they contact you ahead of time? And what do you offer
Yes.
for them?
Yes. We see a lot. I see a lot of patients from out of state, from the other side of the country. International patients. One of the benefits of the internet is that people have access to resources to guide them to the right clinician, which I think
Yes.
is really important, because I think in the bad old days, people just believed whatever their local physician told them and took it as gospel. I
Yeah.
think now people are becoming far more informed and educated, and there are many professional societies and other referral networks with very reputable and reliable people that can guide you regionally or and beyond to people who are the thought leaders and the best possible clinicians to tend to these issues.
Absolutely. And do you offer I guess you do telehealth in the states in which you're licensed?
Yeah.
Yeah. Me
Absolutely.
too. I offer online consultation where they can still contact me if they're out of another state, to at least initiate some type of guidance.
Right.
They're not my patient necessarily, but at least I can guide them through.
Yeah,
You need this, or
and
go see
I
that doctor.
offer the same sort of services as well.
Yeah, it helps a lot, because not everyone can travel, especially
Yeah.
if it may not be
Right.
something
Yeah.
they need to travel for.
And it's useful to people in those situations to have a good sense of, is there a high suspicion that this is what it could be, and then they'll make their way, whatever, however possible, to seek care.
And if someone travels to see you and they need surgery, how long do you have them stay in town?
So if they're having surgery, I generally ask that they stay local for at least 48 hours.
Okay.
Mostly, somewhat just so I can keep an eye on them and they can see me before they leave. And also, as you know, with laparoscopic surgery, with the carbon dioxide, the CO2 that we use for inflating the abdomen, usually not too comfortable if there's any residual CO2 in their abdomen going on a pressurized airplane.
Yeah.
But yeah, that's pretty much it. As long as they're feeling up to it, 48 hours later, they can.
Yeah, that's really good. Were there any questions I should have asked that I didn't ask?
I don't think so. I think we covered
I'm just
quite a lot
fascinated.
of ground.
I learned so much. This has been a great hour. I learned, I guess I still kind of remembered endometriosis the way that I was taught.
Right.
But all these newer kind of innovative, evidence-based stuff, I didn't know about it. So
Yeah, I mean, it's. I think it's really imperative of people to seek out what the conventional thinking is now on treating things. You can't keep your head in the sand and expect to be delivering the best care possible.
yeah, this is true. And so it's kind of fascinating how many people still do that. I don't know. Okay, my friends, that's it. That was the end of HerniaTalk Live. I had a fantastic time with Dr. Orbuch. I hope you all did too. This was so enlightening. I know that I'm going to take better care of my patients now that I know more about endometriosis and other reasons for female pelvic pain. I thought I knew a lot, but I can always learn some more. So thank you, Larry, for your time. I do appreciate it.
My pleasure.
A long day. And for those of you that were watching, do go to my YouTube channel at HerniaDoc and subscribe so you can continue to watch all of these. And I will soon post about my new podcast. So you can do HerniaTalk Live as a podcast. You can be driving and listening to it. And I'm really excited that we're doing that now. So thanks, Larry, and thanks for everyone else who's watching.
Thank you.
Thank
you. Have a great evening.
I appreciate it.
Bye now.